Okay, so let's start. Do we really aspirin loading for STEMI? And for years, we thought that everyone after an age of 45 or 50 should be on aspirin. Ask your doctor, or at least patient at risk for coronary artery disease should be on aspirin. And most recently, papers have come out showing that actually the damage, the potential risk of bleeding is greater than the potential benefit for primary prevention. And now there is ongoing back and forth guidelines and documents who should be on aspirin for prevention exactly. How do we find patients that are will benefit more from the aspirin than the damage of bleeding? But we are sure that aspirin is an integral part of secondary prevention and for the treatment of acute myocardial infarction. And this is part of the quality assurance criteria that everyone that comes with chest pain to the emergency room will get aspirin within 10 minutes of arrival. But do we really need it? Do you see my screen? Hello? Do you see my screen?
Yeah, doctor.
Okay. So those are the guidelines, American College of Cardiology and the American Heart Association guidelines from 2004, giving class 1, aspirin should be chewed by patients who have not taken aspirin before presentation with STEMI. The initial dose should be 162 to 325 milligram. Although some trials have used enteric-coated aspirin for initial dosing, more rapid buccal absorption occurs with non-enteric-coated aspirin formulation, giving level of evidence A for 162 milligram and level of evidence C for 325 milligram. And the small text says, unlike fibrinolytics agents, there is little evidence for the time-dependent effect of aspirin on early mortality. However, data do support the contention that a chewable aspirin is absorbed more quickly than one swallowed in the early hours after infarction, particularly after opioid therapy. The 2012 European guidelines say that aspirin should preferably be given orally, including chewing, not recommended chewing, to ensure complete inhibition of thromboxane-dependent platelet aggregation, but may be given intravenously in patients who are unable to swallow. And convincing evidence for the effectiveness of aspirin in addition to fibrinolysis was demonstrated by the ISIS-2 trial, in which the benefit of aspirin and streptokinase were seen to be additive. The first dose of 100 to 300 milligrams should be chewed or given intravenously, although at a lower dose range, and a lower dose, 75 to 100 milligrams, given orally daily thereafter. The 2013 ACC-AHA guideline for the management of ST elevation myocardial infarction kind of molded the recommendation, and actually they mentioned that emergency medical dispatcher, the ambulance people, are trained to instruct patients with possible STEMI symptoms to chew non-enteric-coated aspirin, 162 to 325 milligram, unless contraindicated while personnel are en route. This is the only place in the 2013 guideline where chewable aspirin is mentioned. And this is from the table. Aspirin 162 to 325 milligrams should be given before primary PCI. Level of evidence being now, they decrease the level of evidence. And after PCI, aspirin should be continued indefinitely with level of evidence A. And the table, aspirin 162 for people who are going for primary PCI, 162 to 325 loading dose before procedure, 81 to 325 milligram daily maintenance dose. With those who receive thrombolytic therapy, again, the same dose, 162 to 325 milligram loading dose. Nothing is mentioned on chewable, and 81 to 325 milligram dose indefinitely thereafter. And adjunctive and antiplatelet therapy with fibrinolysis and aspirin and clopidogrel loading for patients below 75 years of age, 75 milligram dose of patient above 75 milligram should be administered to patients with STEMI who receive thrombolytic therapy. Aspirin should be continued indefinitely. Please note again that the chewable part disappeared from those guidelines. The 2017 European guideline for the management of patients with ST elevation says aspirin, oral or IV, if unable to swallow, is recommended as soon as possible for all patients without contraindication. Aspirin can be given orally, including chewing or IV, to ensure complete inhibition of thromboxane A2-dependent platelet aggregation. For patients receiving fibrinolytic therapy, the first dose of aspirin should be chewed or given IV, and a low dose given orally thereafter. Again. So all those guidelines point to the ICIS-2 trial. And in the ICIS-2 trial, which was published in 1988, 17,000 patients within 24 hours after the onset of suspected myocardial infarction, not STEMI. At that time, the concept of STEMI versus non-STEMI was not established. Patients were randomized to streptokinase, 1 month of enteric-coated aspirin 162.5 milligram per day, both treatment or no treatment. The primary endpoint was 5-week vascular mortality. Those who allocated to oral aspirin, the dose was given daily for 1 month, starting immediately with the first dose crushed, sucked or chewed for rapid antiplatelet effect. So the original study, the only study that actually looked on outcome of patients with STEMI, gave enteric-coated aspirin that now is no longer recommended. All patients that received aspirin received chewable aspirin. So actually, we don't have separate data to know if this oral chewable loading dose did something. But it became part of the routine and standard of care. And indeed, the study showed that streptokinase was great, aspirin alone was great, and the combination had additive effect. But again, what was the contribution of the oral chewable first dose has not been established. Now, There is this paper that is not mentioned a lot, but it was published in Circulation in 1985, and they looked on what actually the low dose of aspirin is doing. And they claim that low dose of aspirin actually does not cross the liver when we swallow it. And it exerts its antiplatelet effect in the portal circulation, while being absorbed by the gut until it reaches the liver and deacetylated, it acetylates the COX-1 in the platelet and exerts the effect because the platelet continue with the blood flow. While 81 milligram, 75 milligram here probably does not have systemic effect. It is not antipyretic. It doesn't work against pain. Only at higher dose, it treats the systemic circulation. And probably when we give it IV, bypassing the liver or even chewable through the buccal mucosa, we bypass the liver and get systemic effect. And then, since the aspirin is COX inhibitor, non-specific for COX-1 and COX-2, if it is reached systemic level, it can cause COX-2 blockage, and this might have deleterious effects that will go. So here, I don't have more clinical data, but I am now toggling between animal studies and clinical data to show some potential adverse effects of the aspirin loading. So we have shown, this is from 2008, that when we give atorvastatin pretreatment to mice, we reduce infarct size. And here we see in the wild-type mice, atorvastatin for 3 days significantly reduced infarct size. It was not seen in enos knockout mice or in inos knockout mice, suggesting that both enos, inos, and NF-kappa B are essential. Now, well, what is a clinical study showing that statin reduce infarct size? We give all patients with acute coronary syndrome, we gave them high dose of statins, mainly atorvastatin 80 milligram based on the small scale miracle study. But do we have evidence that it reduced infarct size? So in this paper, patients that underwent primary PCI for STEMI within 12 hours after symptom onset were randomized to atorvastatin, 80 milligram, before PCI and 5 days after it, or a control group, 10 milligram daily after PCI. All patients received aspirin 300 milligram and clopidogrel before PCI. So they did cardiac MRI and nothing. Atorvastatin did not reduce infarct size. Myocardial salvage was 37.1 with atorvastatin high dose loading and 46.9 with atorvastatin 10 without the loading. In other studies, the Rosemary study, 185 patients were assigned either to an early high dose of rosuvastatin group or to a conventional low dose rosuvastatin group. Placebo loading and 10 milligram maintenance for 7 days. All patients were treated with aspirin and clopidogrel before primary PCI. Infarct size, no difference. So in contrast to the animal study, and I showed one example of our lab, but there are many studies showing in various animals that statin reduce infarct size, but not in patients. And the difference might be related to aspirin, because in the animal studies, so far, none of the animals received aspirin, while in the clinical studies, all patients receive aspirin loading. So in 2007, we conducted a study looking for the effect of aspirin. So we gave 3 days of atorvastatin pretreatment with and without aspirin, 5, 10, or 20 milligram per kilogram, given intraperitoneally just before reperfusion, at 25 minutes of coronary artery occlusion. We reperfuse for 4 hours and look on infarct size, and we can see now that aspirin alone had no effect on infarct size. Atorvastatin reduced infarct size, and aspirin added to atorvastatin dose-dependently blunt the effect. Interestingly, aspirin, when given at occlusion here, blunted the effect of atorvastatin, but when it was given at reperfusion, not 5 minutes, but at reperfusion, did fail to block. So can it be that the aspirin that we give to all our patients with STEMI blocks the potential effect of statins, and therefore the clinical studies are negative? Another example is ticagrelor, and this is a study from our group in 2014 that 3 days pre-treatment with ticagrelor reduced infarct size. Here we see that it reduced the infarct size. Clopidogrel, despite achieving the same degree of platelet inhibition, had no effect of infarct size. This is CGS. This is adenosine receptor blocker. It didn't do anything, but ticagrelor with CGS, the protective effect was blocked because the effect of ticagrelor is mediated by adenosine. Now, when we gave aspirin, again, before reperfusion, 5, 10, and 25, dose-dependently, we attenuated the effect of ticagrelor. The effect was blocked with SC5815, which is a COX-2 inhibitor, but not by SC560, which is a selective COX-1 inhibitor. So the protective effect of ticagrelor is COX-2 dependent. And when we give aspirin together with the ticagrelor, we eliminate at least the initial loading, the effect of the initial loading dose of ticagrelor. Now, the Plato trial showed that ticagrelor had major effects in patients with acute coronary syndrome. And there was a question why it didn't work in the North America patient. And then there was this question whether this is a low dose of aspirin versus a high dose of aspirin used by the American patient. And the high dose of aspirin blocked the advantage of ticagrelor. And we thought that our model showed some explanation why high dose of aspirin, at least the loading, may affect the outcome. In this trial, they tried to see if pre-hospital ticagrelor loading will reduce infarct size or induce the Atlantic trial. So 1,862 patients with ongoing STEMI of less than 6 hours duration were randomized to receive pre-hospital in the ambulance en route to the hospital versus in-hospital treatment with ticagrelor. But all patients received aspirin. And actually, it was a negative trial. Absence of ST segment elevation resolution, pre-hospital, in-hospital. None of the endpoint reached statistically significant, while no effect on mortality, nothing. They claim that the time difference between the pre-hospital and the hospital was only 31 minutes, the median time, which may explain it. But it can be that this is only the effect of aspirin. Now, post-conditioning. This was described in 2002, 2003. The short episode of occlusion-reperfusion at the beginning of reperfusion reduced infarct size in animal. It drew a lot of attention, and clinical trials try to imitate it. But all trials of ischemic post-conditioning, at least a large trial that were well conducted, were negative. In the Dynamis-3 ischemic post-conditioning trial, routine post-conditioning, in addition to primary PCI, failed to reduce the primary composite outcome of all-cause death and hospitalization for heart failure, where the post-conditioning may offer cardiac protection in an enriched STEMI population remain unknown. Now, this is another negative study published in European Heart Journal in 2012. Infarct size, 27 with post-conditioning, 22 with control, not statistically significant. Myocardial salvage index yet was positive. Now, we published last year in rats that aspirin given before reperfusion blocked the infarct size limiting effect of post-conditioning. So the rat underwent, here is infarct size as a percentage of the area at risk. Post-conditioning reduced infarct size. Aspirin alone has no effect, but aspirin blocks the effect of post-conditioning. The fourth and the last example is morphine. This is an old study that suggested that morphine in animal reduced infarct size. They also claim that ibuprofen reduced infarct size, but aspirin not. Now we don't like ibuprofen with myocardial infarction because it increases the risk of rupture. But aspirin blocked the protective effect of morphine. This is another paper showing that morphine can reduce infarct size in animals. Yet, in using MRI, morphine does not have effect on infarct size. Myocardial salvage is the same. Myocardial salvage index is the same. Can it be that the aspirin loading blocks the potential effects, protective effect of morphine that has been described in animal study? So there are several clinical questions. The animal models, there is external ligation of the coronary artery, not a thrombus. Do we really need rapid onset antiplatelet drugs? Can this be achieved with other antiplatelet agents? Remember that in the ISIS too, people even didn't get heparin. At that time, you didn't think that you need heparin for after streptokinase. There was no clopidogrel. There was no 2B3A inhibitors. Does aspirin have other unique property besides its antiplatelet effect? Can it be that by using other antiplatelet agents that do not block COX-2, we might be able to benefit from agent procedures that protect against ischemia reperfusion injury, minimize reperfusion injury, and improve prognosis beyond reperfusion? So this is kind of a summary of the finding. If we start with ticagrelor, ticagrelor block ENT1 that leads to reabsorption of adenosine, reuptake from the interstitium, increasing the adenosine level in the interstitium. Statins activate ecto-5 nucleotides that secrete adenosine into the interstitium. The adenosine activates its receptors that with downstream activation of COX-2 and iNOS. iNOS activate COX-2 by S-nitrosylation. Opioids, again, I show you some suggestion that there is an effect with aspirin or COX-2. Unclear. Might be that this is another pathway. Post-conditioning, well, we blocked it with aspirin, but we don't know if post-conditioning work directly on the COX-2 or activate somehow and increase the adenosine secretion. The role of adenosine was established in the late form of ischemic preconditioning, but actually nobody checked if COX-2 is also involved in the immediate form, the classical form of ischemic preconditioning. So here is a classical picture of a patient with acute myocardial infarction, acute coronary syndrome with oxygen. Those are, we knew for years that everyone with chest pain and acute myocardial infarction should be on oxygen, and these were the guidelines until the 2017 guidelines changed it. Oxygen is indicated in patients with hypoxemia. Routine oxygen is not recommended in patients with saturation above 90. So we have changed a lot of the recommendations that we had in the past for treating STEMI. The oxygen, the routine use of lidocaine, and even IV beta blockers. It might be that based on the discrepancy between the animal studies and the clinical studies, it's the time to test the hypothesis that nowadays we can use alternative to aspirin and see if omitting aspirin or replacing it by other drug will result in better outcome